This work sits alongside other projects, and there are many projects as we described, but I'll just mention a couple because these are both really significant projects that are happening right at the moment. The National Palliative Care Health Needs Analysis, which was done by the Palliative Care Council, and that was just published on the 30th of June and is available on the Palliative Care Council website, and Wayne's talking about that later. Yeah, so I won't say anything more on it except that that's a really significant piece of work to sit along this, because that is how we determine what our population actually needs. The Palliative Care Workforce Service Review, which Simon, and I'm trying to see where he's hiding, there he is at the back, has been the clinical lead on the Palliative Care Workforce Service Review undertaken by Health Workforce New Zealand. And I'm not sure, but a number of you will be familiar that there are all of these workforce reviews being undertaken through Health Workforce New Zealand at the moment. And what that workforce review needs to do has done and has recommendations out, and again they're on the Health Workforce New Zealand website, and they are looking for feedback still. Simon, we had that conversation the other day.
Interesting system or interesting process, but I think the letter doesn't actually specify feedback, but I think feedback will be warmly received.
Yeah, thank you, because these pieces of work have to all sit alongside each other. Otherwise, nothing will change and nothing will work. So all of these pieces of work need to inform the others. And so do take an opportunity to have a look at that workforce review and provide some feedback. It proposes a series of clinical networks and what that might mean and how that might look. You'll see if you look at the website. So sorry, Simon, I'm not trying to to steal your place, but just give it a plug. So, where do we go to with this? We know that we need to do something different. We know we need to have a systematic approach to how we might look at defining palliative care services in New Zealand. So, what will come out to you for consultation very shortly is a document that looks like this, and it's a consultation framework. And there's a number of things in here which I'll just describe because it is. Once we have agreed this will be the basis on which we move forward around palliative care services. The Ministry of Health will lead the work around palliative care services alongside all of the other projects. So what we've done to start with to undertake the consultation is put together a framework which is based on the Australian model. The Australians have it's called a role delineation framework, and some of you may be familiar with that term, and others not. But what a role delineation framework is basically is a resource and capability framework. So again, it's right people, right services, right time. So and differentiating and describing what's at each level and how they link together. So the Australian approach differentiates. Now, you saw that pyramid before with Kerry Thomas. That's not, and you'll see a lot of this work is not anything particularly new. It's just the way it's actually put together to lead the work forward. So down at level A, that's primary care, which is where most palliative care is actually delivered by generalist providers. And I think in the Australian model, when they talk primary care there, they're also meaning the generalist providers rather than just primary care as we know it in New Zealand, being the GP teams, etc. So they're looking very much at the generalist providers. So the population, most people will receive their palliative care from primary care. There are a number of clients who, patients, families who the care will be provided predominantly still through primary care, but with referrals backwards and forwards, consultation and advice provided by the specialist providers. And then at the top of the pyramid is the specialist providers who provide the complex care. So that's exactly the work that Kerry was talking about before, reserving the specialist services really for those who have complex needs, because if you don't have complex needs, what we need is a generalist provider's capacity to actually be able to meet the needs of most of the population. So the framework, and you probably can't really read it, and it's but have a look when you get the information in when it comes out for consultation. Effectively, it talks about primary care providers being everywhere, specialist care, and it's got 3 levels, and that's one of the questions that will be talked about in the questionnaire, because we really need feedback around this. This is the Australian approach. They've got 3 levels of specialist palliative care, and a lot of people are saying, do we need 3 levels of specialist palliative care in New Zealand, or actually do we need 2? So that's one of the things that we need feedback on. We need to know what will work for the New Zealand context, because we don't want to just holus bolus adopt someone else's approach. And it's looking at so level 1, often being around community nursing teams, GP linkages, but I guess, and I won't go into all of the detail, but I guess one of the things that's different from what we have now, because a lot of people can say, well, sort of, is that so different from what we have now? What it actually requires formalised partnerships and linkages, not based on relationships and goodwill and some historical practice. So, and potentially that's where, in the future, some of those things actually then become contracted, because then that's how they become enforceable and can actually change the structure by the way the contracts are designed. So making it formal is actually a really important way of changing the services, rather than, again, relying on goodwill. We have a very shrinking palliative care specialist workforce. If you think of that, not only is the whole population ageing, but so is the palliative care workforce ageing, and we need to be really mindful of how we best use who we have. Again, that's a bit more descriptive around, and that's in the framework, a bit more descriptive around how the framework works. One comment that's been made to me, which I think is probably quite an interesting one, and again, I'll make sure that that's one of the things that we consider, is at level 1 in there, it talks about a multidisciplinary team. Level 2 and 3, it talks about an interdisciplinary team, and what does that look like in practice, and what does it mean? So that's the framework that they've got, and I'll go back to Palliative Care Australia and ask them why it's differentiated, but be really keen to get also feedback in terms of what that might mean from feedback, or from what you all thought about how it would be applied or implemented, and is there any difference? Okay, well, we've talked about Australia, and that's the work that that this framework is based on. But I also thought I'd just like to talk to you a little bit about the NHS approach, and again, following on from Kerry Thomas, not repeating what she's said, but there's a piece of work that's been going on, which is a funding review around how palliative care services are being delivered in the UK. And I think it's really significant to look at that alongside, because clearly what happens beyond just describing and defining the services is then how they'll be funded into the future, because again, we have to do it differently, because what we have got now is a model that's not going to be sustainable. So have a look at palliativecarefunding.org.uk. It's a really interesting site. What they did was they looked at what services are available, how they're funded, and what improvements could be made. And you see, it's very hot off the press, because the final report was only published on the 1st of July. They're again looking at how you might describe palliative care. That's been one of the things they've done. And so this is from their interim report when they first started collecting the findings. And you'll see they've differentiated palliative care in a slightly different way. But I think is really interesting to look at as well, because if you look, it's that same pyramid, and what they've described on the bottom is called universal palliative care services. And again, that's those services that are delivered by generalist or non-specialist, but also health and social care providers. So you'll note that with the UK work, they look also quite a lot at this other social agencies, which we don't tend to do a lot in New Zealand, but how it actually fits across a whole social model rather than just health as a silo. And they're looking at packages of care and patient-level needs. The middle was around core palliative care services, so that's people whose primary focus is palliative care, and then specialist palliative care services delivered by specialist providers. So it's that same sort of mix in terms of people as to which population would be served. They've described in the report what dedicated palliative care services are. So I won't read them out to you, but if you have a look, and I'll just pick out a few things there. One of the things that was really most noticeable in some of the work they've done is around how absolutely critical 24/7 access to care is. And that's one of the key things that's come up. They've done a big questionnaire asking consumers, providers, a whole raft of people, and it describes who they all are in the report. But that was one of the key things that was actually recognised, was access to 24/7 care. It talks a lot about care and support for families, the psychological and bereavement support. As I said, it talks about the health and the social care sector, looking at absolutely claiming, I guess, for specialist palliative care services, the role of education of not necessarily the public, but recognising that actually, if we want to enhance the capacity of the generalist providers, that's a real shift for specialist providers, because they have to focus much more on being able to support and provide service to generalist providers. And Kerry Thomas talked about that as well. And then how the services fit with the other services. I'll just give you just wanted to tell you a couple of things around the funding that's not on there, but when they asked people who should be funding what, they asked this question around what should the state, or what we would describe as the Crown, I guess, in New Zealand, fund, what should society, or as we would probably more describe as community, fund, and what should be shared funding around who should provide. And they differentiated out the different types of services. And assessment was, of course, the service that almost absolutely everybody decided that should be fully funded by the state, and so that's marking that out very much as a core palliative care service. And the coordination and inpatient care, again, were services that they thought that should be funded by. But one of the things to remember, I guess, in bearing this work in mind, is that in the UK, hospices, for instance, are funded at about 40% of less than 40%, very low Crown funding or state funding anyway. So we have to be mindful of that in terms of thinking about what this is, because the voluntary sector, the community, provide funding for a whole raft of services that are funded for currently by the state in New Zealand. So if we look then at what this framework needs to deliver in New Zealand. So I've done some initial key stakeholder feedback. So I've talked with a variety of organisations, and the questionnaire is just under development. It will be out shortly. And it's a questionnaire to be distributed very widely. It's not around trying to keep a closed number of respondents. Basically, we want a very wide feedback, but also think, and you very well may find that you get it sent through organisations that you're a member of, organisations that you work for, coming across it will come through the cancer networks. So hopefully it will come to you in many ways, and potentially you might be contributing to feedback in wearing different hats, but we want as much feedback as possible around what this might mean. And the report was intended to be completed by the end of September, but in fact we're going to extend the deadline simply because there's been such interest, and as people have understood, heard more about it, realise that actually we need to be doing lots more consultation and making sure that a lot of people get an opportunity to see what it might mean for them.